But I think I want to turn my attention to the empirical question. So I think I find it very interesting that Winnie has used a diagram to talk about the possible ways um, in the aftermath of the pandemic. The first wave being the burden on the COVID-19 patients, and then the burden on the non-COVID-19 patients in the psychological and physical health burdens. I think these are the things that whether we are policymakers or policy analysts are interested in, is that how do we attack these questions empirically in the best way? So one thing that we did in the Office of the Actuary is that we go around and look at different sources of data and try to answer that question empirically, although not perfectly, because a lot of the data sets that were prepared are not prepared specifically for this type of a scenario. So what we did to answer that particular question is that when we were building a gigantic COVID model, one of the questions that we had to answer is that what's the intensity impact of delayed care, which means that if somebody's somebody missed a certain preventive care screening and waited like 4 months to be able to see his doctors again, or somebody's waiting with multiple chronic conditions and delayed regular monitoring or in-person visits to his primary care physicians, then what kind of impact would that have on that patient's physical functioning and also health conditions 3 months down the road? Will the situation become worse and will cost the healthcare system even more to treat the patient? Like most recent Kaiser Family survey shows that about 48% of patients were experiencing some kind of delay of care, but most of them seems to be non-significant delays, and they report only 11% of that 48% were experiencing worsening symptoms of their chronic condition, and so this is something that we are also need to keep in mind. Well, one thing that we did empirically is to go back to the MEPS data, which is the Medical Expenditure Panel Survey, to look at what happened to people who experience delay of care. Although in the MEPS data, the delay of care occurs for a variety of reasons. They might be because of the cost of care, because of access of care, or because a variety of different reasons. So we look at that particular variable and divided the sample persons into two different groups, delayed group and non-delayed group. And it turns out that after this some simple analysis, it turns out that the delayed group experienced a 6% higher intensity of care than the non-delayed group. So if you take that into account and consider that, for Medicare patients, at least for Medicare patients, during the first 3 months of pandemic, the care volume and utilization has been down almost 40–50%, but the spending is down about around 30%, if I remember that correctly. So and not all delayed care are completely foregone, and some of the delayed care actually you can see from the Kaiser Family survey is that 75% of the respondents they expect the care to be resumed within 3 months. So they expect to see the doctors pretty soon after the physician's office are open again. So it seems to be that different sources of data seems to be pointing to the fact that the delay of care might not be causing a significant amount of increase in the burden and also the expenses of treating those patients because of the delays. And so one of the questions I have for you and maybe for others is that, what are the best way to attack these questions empirically, and what are the best data sources in the US that we have, that we can have access to, that can help us help answer this question more scientifically.